present this viewpoint. Well, I'll be speaking for the next few minutes on TOF repair, where how close to the ideal can we get. I'll just briefly go through the history, and we all know from 1944, when the BT shunt was done, to current, a lot of water has flown in the management of tetralogy of fellow, right from transatrial approaches in the 60s to 80s to transatrial transpulmonary repairs. And as Dr. Subramaniam rightly suggested, it's not the survival we are looking at currently, but it's the quality of life and what are the implications in the long term on repair of tetralogy. But of course, from 2010 onwards, there's been virtually tetralogy has no mortality as such in the immediate postoperative period in uncomplicated tetralogies. But then the practice of pulmonary valve sparing procedures, reduction in transannular patch incidents, and also this increase in reinterventions with advent of transcatheter pulmonary valve replacement procedures, all these have sort of made the management of tetralogy a little more complex, but then of course, in the hope that we get the best results in tetralogy of fellow. Whenever we see it's a normal or an ideal, I will see it from three viewpoints. One is what has been physiologically corrected, what has been anatomically corrected, or have we achieved a functional correction with compromise either in physiology or anatomy, so that this repair can give rise to, can take care of a long-term in the patient. So let us closely examine what is the normal anatomy on the right side of the heart. We know that tricuspid valve is larger than the mitral valve. It's a tripartite compliant right ventricle, which is extremely thin-walled. So to take in the diastolic, it's got a very good diastolic function. There is a subpulmonary conus which separates the tricuspid from the pulmonary valve. There is no gradient inside the right ventricle. Obviously, it's an intact septum. Coronal septum is in a normal position. Aorta is totally committed to the left ventricle with no override. Pulmonary valve is larger than the aortic valve. No right ventricular outflow tract gradient. No supravalvular stenosis or turbulence. And more importantly, there is smooth continuum of the right ventricle into the main pulmonary artery. I think with this idea as to what is there in the normal heart, let us closely examine what tetralogy has to offer and also what is the surgical anatomy after the correction. So I think to a learned audience, I won't be going very much into details, but just sticking to the point, because all of us know what's the anatomy of tetralogy. But just to sort of highlight a few points, we do see an enlarged aorta, aortic root, and there is very degree of override of the aortic valve. And the aortic arch could be either side, which does complicate the intracardiac anatomy, particularly the anatomy of the VST, whenever these arches are on the right side. There is certainly hypertrophy, anterior deviation of the coronal septum, varying degrees of right ventricular hypertrophy, lengths of the infundibular chamber. It could be a sort of a channel or slit-like, or a sort of an os at the start of the infundibular chamber. Pulmonary stenosis can be at multiple levels. VST can be absolutely different from case to case. There are many angles, many planes of the VST, depending to the extent of aortic override, the aortic arch, and the coronal septum development. There could be many numbers of VST, multiple VSTs. And of course, you can have coronal septum hypoplasia and the VST extending right up to the pulmonary valve annulus. In addition to this, to make the matters more complex, you have coronary arteries, which are anomalies in 5% of these cases when the LED particularly crosses the right ventricular outflow tract. So all these influence the that repair, the approach, and also play a role in the long term. A few comments on right ventricular outflow tract obstruction, which is because this is one of the most important things which has got a bearing in the long-term behavior of the tetralogy of fellow patients. So you can have a subvalvular right ventricular outflow tract obstruction at a very simple level. when it is completely correctable by resection, or sometimes we do a patch enlargement, particularly opposite the coronal septum, to relieve the outflow tract obstructions and the gradients. But then, of course, whenever we put a patch, the dimensions of the patch also determines how they behave in the long term, because that is a bit of an adynamic segment. And whenever a ventriculotomy is done, obviously, there is some sacrifice of the coronary arteries. Now, coming to the valves, you can have varied valve morphologies. It can be thick dysplastic leaflets to thin pliable leaflets. It could be bicuspid, it could be tricuspid, and there could be difference in sizes of the leaflets. So this also has a bearing in the long term. And annuli, pulmonary artery annulus, which it could be small, it could be normal, or what we consider as nearly adequate when the Z values is less than -2. And then an intact annulus, we know, has a protective effect on the right ventricle. And if it is reasonably normal sized, they do pretty well in the long term. Supravalvular areas, commercial narrowings in the pulmonary valves, main pulmonary artery. And in this case, more than the main pulmonary artery and the branch valve, it's a LPA origin, which plays a big role, because that's one of the watershed areas where in tetralogy of Fallot in the long term, whatever we do, that seems to be a problem and may require interventions, multiple interventions in the future. Earlier surgeons used to call things as total correction. So whenever we were talking of tetralogy, it was called as total correction. But now in the long term, I would say instead of a total correction, I would use the term as functional correction, in the sense that we do all the corrections to restore a certain degree of function, though totally it may not be truly anatomically right. So therefore, we have got various types of approaches. Earlier, in the earlier era, it was a transventricular repair of tetralogy, when there was a ventriculotomy done of varying lengths to approach the VST and resection of the right ventricular outflow tract. Then came about the transatrial transventricular approach, which is currently utilized pretty well or pretty frequently. And then, of course, then we have the transatrial transpulmonary approach, which avoids a ventriculotomy or makes a very small ventriculotomy, which, according to some of the groups, is the preferred approach. But then, of course, this is limited by the annulus and the pulmonary valvular anatomy. Then the types of right ventricular outflow tract repairs has been the transannular patch, which all of you know, it's across the pulmonary annulus. There was a case made for a mini transannular patch by Kawashima. It's a limited ventriculotomy, and now also people use it when the transpulmonary approach is used. Then with a aim of having a little bit of competence of the pulmonary valve, we had the monocusp, we had the initial single monocusp, then the bicuspid monocusp valve by Graham Nunn. That seemed to be a thing, and so it's pretty quietly used even today, with varying degrees of success in the long term. And then, of course, came about a huge numbers of pulmonary valve sparing procedures, which appears to be the fashion of the day. And we all try to achieve various degrees of competence in the hope that these procedures protect the right ventricle in the long term from pulmonary regurgitation. So this is just a very small clip where we show that's the pulmonary valve which is saved. There's an outflow patch, there is a pulmonary arterial patch, and in this case, you try to save the pulmonary valve. I'll quote one study which appealed to me, because this is one of the studies which was neutral, in the sense that we have had a lot of long-term reports from individual centers. But this is from the Pediatric Cardiac Care Consortium, who saw about 3,000 plus cases in over a period of 30 years. And as we know, the survival is pretty good. And but then there is a dipping graph saying that there are issues in the long term. But if you see the hazard function and the mortality, after the initial hazard in the first year, it seems to tail off, and from till about 4 years, and from 4 to 6 years, there's a gradual rise in the hazard function as the follow-up increases. And so it does show to us that tetralogy, how much ideally we repair, there is a certain amount of attrition in the long term. Now, if you see what is the influence in the long term about sex, age, then uh, repair strategy, then tetralogy, repair type, and whatever, what really stands out are twofold. One is if there is a genetic abnormality, as well as like a Down syndrome, has got a huge bearing in the long term of results of tetralogy, and also the repair strategy, whether it's a two stages, initial palliation and later on. But otherwise, including the repair strategy, all the other repair strategies, whether pulmonary valves, competence, non-competence, has really not shown very much in the long term. So the authors concluded that the long-term survival after simple tetralogy of Fallot is excellent universally. Stage repair and non-valve sparing operations were negatively associated with survival in the early postoperative phase, but not in the late postoperative phase. So what is the anatomy after surgical repair of tetralogy? We do have atriotomy and we may have a ventriculotomy. So the scars of these areas could have an implication in the long term. In the tricuspid valve, there is certain amount of fixity of the tricuspid annulus. Perhaps is a little septal mobility is reduced, and there could be varying degrees of tricuspid regurgitation, though, of course, in the current techniques, we aim for 0 TR, but you may be left with a mild or trivial tricuspid regurgitation. RV diastolic dysfunction is one thing which the patient carries throughout his life in tetralogy of Fallot. Right ventricular subendocardial fibrosis, microinfarcts, small areas of RV infarcts due to coronal artery division in the right ventricular outflow tract are inevitable and as part of the repair. The RV outflow tract is usually muscle bound, much more than the normal. And in the RV outflow tract and tricuspid tap, we have got a certain amount of adynamic segments. So VST is large, an adynamic patch, abnormal right ventricular outflow tract leaflets, pulmonary artery bifurcation, and RVOC stents complicate the matter further in the long term. So how close to the ideal are we? I feel we are very far from it, barring exceptions, but certainly it's not a normal anatomy in the true sense. The best we could perhaps get to the ideal functional physiology after tetralogy is in a child who has a transatrial VST closure without a residual defect or PFO, no tricuspid regurgitation, no ventriculotomy if we can avoid it, and open RVOT with no gradient or small dynamic residual gradient around 15 to 20 millimeters of mercury, normal size pulmonary annulus, mobile tricuspid or thin bicuspid aortic valves, good size distal anatomy, little or no pulmonary regurgitation, intact moderator band, and ECG with narrow QRS complexes. These are the baggages that we are left with in the long term, leading to some patients going in even for heart transplants and sudden deaths. So in conclusion, TOF repair is an excellent functional and physiological repair to near ideal conditions when pulmonary valve leaflets and annulus are Z of -2 or greater. Anatomical issues remain RVOT, LVOT, and pulmonary arteries. Pulmonary regurgitation and pulmonary stenosis issues confer reinterventions in the form of surgical or transcatheter PVR or resurgical RVOT relief. It does guarantee a pretty normal lifestyle up to 25 to 30, 40 years. Exercise ventricular dysfunction is particularly seen in residual PR and those with RV fibrosis. And I would say that the total correction of tetralogy meets around 70 to 80% close to the ideal, but residual abnormalities remain and have an influence in the long term. Thank you so much.